Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of Thyroid Answers podcast. No Dr. Erica today, no sub fill-in Dr. Kelly Halderman today. It is just me and of course my fabulous guest, Dr. Carrie Jones, the one, the only, the queen of hormones, the medical director of Precision Analytical, and the queen pin, king pin, binary pin. I don't know what you want to call it, but this is the person when I have hormone questions, I kind of text and pepper with emails and messages like, hey, what am I missing here? And so we always have this conversation. Like we actually just had this conversation off audio, off video. Like sometimes you need an objective person to look at stuff and help you see something that maybe you don't see. So Carrie, thank you so much for coming on the podcast. How are you today?
Eric, oh my gosh. Thanks for having me back. I always love talking to you. You're my go-to thyroid guy. So this is amazing. I'll help you with hormones and you blend the thyroid, and then between the two of us, we can get a lot of education out there.
Yeah. So today, I want to kind of get into the Dutch test. So maybe what you could do is you give us a little bit of insight as to who Precision Analytical is. Some of the listeners know, a lot of people don't, but I'll tell you, a lot of people are using the Dutch test. A lot of people know about it. There's a couple different levels of the test. So why don't we talk a little bit about, as an intro, like who you are. Mm-hmm. Okay. And then we'll talk a little bit about Precision Analytical, and there's a couple different tests that are available, and then we'll get in and just rip a test apart.
We'll talk all sorts about hormone testing. Well, I'm a naturopathic doctor. I am board certified in naturopathic endocrinology, and I have my master's in public health. Hormones, primarily female hormones, is all I've done my entire career. It's what my residency was in when I was in full-time private practice. That's primarily who I saw. And now, like you said, I'm the medical director for a hormone testing company known as the Dutch test. And what's so appropriate is that, TMI, but I'm on day 21 today. So I woke up this morning and went, oh, I have to collect my Dutch test today. Like I can't, with the Dutch test with collection, there's a few things you have to reserve till maybe like your morning supplements, drinking water and eating. You have to wait a little bit until you do your collection. So I woke up this morning and went, oh crap, I have to do my Dutch test. But thankfully, perks of the job, I get to collect my Dutch test often whenever I want to, but then I make it public and I let everyone see my results so that they can learn from it. But the Dutch test is an acronym. It stands for Dried Urine Test for Comprehensive Hormones. And it's primarily urinating on these pieces of filter paper in the morning, 2 hours later, around dinner, before bed. And if you have insomnia and get up in the middle of the night, you'll do it then as well. So that's our flagship test. And it gives all sorts of information around hormones. It's easy to collect at home, which is nice if you're afraid of blood draws or you don't want to go to the lab right now. And it's been an amazing journey to be a part of this test almost since its inception, and then be able to educate about just hormones at large.
Awesome. So I use the test regularly. Most of the people I associate my sphere use it on a pretty regular basis, but for the average person, they've got hormone issues. Let's say they've got estrogen issues and they've got cycling issues. They're struggling with pregnancy, and they're going to get hormones tested. And this is not to bash allopathic. I think there's a place for allopathic medicine. There's a place for functional medicine. And we each need to find our place instead of trying to shoot and kill each other. We need to find a place. And I think if we can get that message out more, same in the dietary community. Yep. There's a place for paleo, carnivore. There's a place for all of these things, not circle the wagons and shoot in. But if somebody's got a hormone issue, a concern, they're going to go to potentially, if they go to a traditional allopathic physician, they might just get blood hormones. What's blood hormones going to tell us that maybe we won't see? What are we going to see in urine versus blood? Why might they learn one thing from blood hormones and learn something maybe totally different from urine hormones?
One of the things, well, first and foremost, for women listening, if you are cycling, you want to collect most of your hormones, especially like estrogen, estradiol, progesterone, in the second half of your cycle. So I said earlier, I was on day 21, it's considered my luteal phase. Most women who have a regular cycle collect around 5 to 7 days after ovulation, usually is in the day 19, 20, 21 range. What drives me nuts, and you as well, is when women say, okay, I got my hormones checked, and I don't know what it means. And I'll say, well, where were you in your cycle? And they'll go, I don't know. It was Tuesday. I was at the doctor, so I just went to the lab. Hormone cycle, and it is a big argument that I hear from maybe traditional allopathic physicians, is that they're like, women, well, hormone cycle, so it doesn't matter when you test them. It does matter. Progesterone is near zero in the first half of your cycle, and then it should rise in the second half of your cycle. We know what a cycle should be, right? And so when it comes to testing, that's numero uno. Number one, women, get your cycle right. If you're menopausal or male, you can test anytime. Then, of course, it doesn't matter. But the second thing is the blood will tell you, the blood is very important, but it will tell you when the basics when it comes to hormones. So for example, you want to check your progesterone, like I mentioned. You want to check your estrogen, which is the potent one, is called estradiol. You want to check your testosterone. Maybe your libido's in the tank. Or maybe the opposite. You've got male pattern baldness or acne, and you're thinking maybe it's testosterone. So it's great for that superficial look at hormones. But unfortunately, it doesn't tell you where those hormones are going. And that's where urine testing, the Dutch test, comes into play. So you make a testosterone. Is it going down a pathway that is going to increase your risk for acne, for hair growth in places you don't want, anger, hair loss? You make an estrogen. How does your body, we call it metabolize or detoxify it? Some of the pathways are a higher risk for cancer. Other pathways are a lesser risk. And so that's what's really nice about the Dutch test, is I have women that say, I got my blood work done and it said I was normal, but I have really heavy periods, or I have fibroids, or I have PMS. And then we run a Dutch test, and sure enough, their estrogen is normal, but how they process their estrogen is not. And that's what's causing their symptoms. So it's like peeling the layer of the onion with hormones.
So like when somebody gets their blood levels done, that's kind of like production, right? Like what's available, what we made,
what's available in the moment,
right?
Available in the moment, what's floating around.
And then if we look at the urine metabolites, we kind of get a better idea of how it worked, right? Or the function or the pathway that's going down.
Yes.
So,
and both are helpful, right? As the owner of Dutch says, they're both different windows into the same house. It's just, you're just taking a broader view of it with the Dutch test.
And I've really gotten to wanting to look at both, right? So if I can get that timing right with somebody, I'll say, look, if we can do the timing right and it's feasible, let's look at your blood and your urine within like a 24, 48 hour period max and see where we're at. Now, it doesn't always work out. And sometimes you see somebody's like, well, I took my blood at the beginning of my cycle, and now I've got the hormone collection when I was supposed to in urine, and you're like, yeah, okay, but I still have it, but what I was looking for was a little bit different. So,
right.
Is it potentially possible that if somebody could have low hormone production in their blood, those values could be low, and we might see some problems on a urine test that may preclude somebody from wanting to take some type of bioidentical hormone, like, hey, your hormones are low in blood, so I'm going to put you on therapy.
Yeah.
But then look at a urine panel and say, yeah, you should not be doing that based on what I see here.
I just had a 51-year-old female who had menopausal levels, actually low menopausal level range of hormones. So, she was struggling, hot flashes, night sweats, joint pain, brain fog, all the things. And she decided to go on hormone replacement therapy. And her practitioner ran a Dutch test, called me to consult, and said, I want to put her on estrogen and progesterone, what have you. But looking at her Dutch test, I feel like this could increase her risk. And in her particular case, a lot of her estrogen, even though it was very low estrogen, it was funneling down a pathway that could increase the risk for what we call DNA damage. And when you DNA gets damaged. We don't like that. And it can increase the risk for, cancer progression or formation. And so I said, it doesn't mean she's a zero candidate for HRT, hormone replacement therapy, but it does mean you should do some diet, lifestyle, supplemental mitigation to let's reduce this risk if she's choosing to go on HRT. Now, to those listening who might think to yourself, well, she's stupid. She shouldn't go on HRT because you just said she's going down this pathway. But she's going down this pathway anyway. So her own estrogen is taking her down this pathway. She's at an increased risk no matter what. So even if she chose never to go on hormone replacement therapy, specifically estrogen, she's still at a higher risk than some other woman on a different pathway because she's the higher risk for DNA damage. So either way, I'm going to try to tell this 51-year-old woman, you're kind of at that prime age range for breast cancer, and whatever you choose, we still have to get you off this pathway. We still have to lower your risk as best we can.
Yeah, and I think that points out a really good point. By knowing which way you're kind of metabolizing things, the way things are going out, we can address those things. Listen, I wouldn't argue that some women may feel better with some added support.
Absolutely.
But if it's going down once you take it, if it's going down the wrong pathway, you're potentially going to be in trouble. We see that with dudes all the time, right? I got low testosterone, my doctor said, so I'm going to go on testosterone therapy, or they're staying up too late at night and watching that late night testosterone boosting commercial, and they initially feel good, and all of a sudden now they've got moobs and they're putting on more body fat, and they're like, hey, what's going on? Well, yeah, your testosterone looks better on blood, but it's also getting converted into way more estrogen than you really want. And go ahead.
We see that all the time where practitioners micro focus on one hormone, especially with men's health and testosterone. Just like you said, men micro focus on testosterone. I'm like, well, there's a lot that goes into testosterone, and there's a lot of places testosterone can convert into. So let's make sure you are not headed down that moob pathway. Let's not get the belly. Let's not get a little flabby because you're just making all this testosterone, and then it's got to go somewhere.
It sounds good, right?
It totally, on paper it does. And
especially when you see somebody like Stallone walking around at 80 and he's ripped and musculature, and you go, that's hormones. I need some of those.
Totally hormones.
There's a lot more to that chemistry picture than meets the eye for the average person.
There was a picture of Cindy Crawford the other day. It was Cindy Crawford as a young model, and Cindy Crawford current. It was her picture. She posted it. Current day, and of course she's gorgeous. But she was like, "Look, y'all. Like I use I have a plastic surgeon. In aesthetics. Hormones and good skincare and diet. Like she's like, I do all the things to continue." Elle McPherson, when she posts pictures, I'm sure she's doing all the things but you have to do it in balance no matter what. You can't just look at these people, Sylvester Stallone, Elle McPherson, Cindy Crawford, and go, well, I'm just going to do this one hormone and that's it. It's like, it's a whole cascade of events. It's a whole big picture you have to look at.
Yeah, and most of us aren't walking around with the same cash flow that those people are to be able to maintain all this.
Most of us are not. Most of us, I remind people a lot of, like, if you had a private chef and a private trainer and, it would be a little different.
So let's break. Yeah, well, yeah. I know that, when you're making 7 or 8 figures like you are, then it's a little different. But, for the small people, right, like me, right. So let's break down this test, right? So for the listeners, when we get this test, it's a 4-part urinary test for the most part. But there's also, if you get the Dutch Plus, which in the beginning, I was a little resistant about that cortisol awakening response, but I now run it, I think, almost on everybody, because I really do want to see what's available from a cortisol perspective and what's being metabolized. So today we're going to focus mostly on the sex hormones, but can you just talk about the difference between kind of the standard Dutch test and the Dutch Plus test?
So the standard Dutch Plus, the standard Dutch test is called a Dutch complete. It's all urine. It's all it is. Just urinate on pieces of paper. And it gives you everything we've been talking about other than the awakening response. So it does test estrogens, estrogen detoxification, phase 1 and 2, testosterone, DHEAS, what those pathways are. We look at cortisol, cortisone, melatonin, plus some other markers like a B12 marker, some B6 markers, a glutathione marker, a DNA damage marker called 8-OHDG. Now, we do check cortisol, and we do check cortisol through the day in that one. It's a grand sweeping cortisol. It's a great, like starter test is the wrong word, but it's a great, like, it's like the khaki pants of hormone testing. Like it sort of covers, it goes with everything, right? It's blue jeans. Like it goes with everything. You can dress it up, you can dress it down. That's what the Dutch Complete is. Now, if you are a little more specific though, in your cortisol issues, meaning most of the time you say, in the morning, I wake up with anxiety. I wake up with panic. I can't wake up. I need a lot of caffeine and I hit the snooze button. I wake up and my pain is bad. I wake up, my autoimmune symptoms are pretty bad. That's when we do the Dutch Plus. The Dutch Plus is a combination of everything in the Dutch Complete. Plus, we add in saliva collection. And thankfully, you don't have to spit in a tube. You just put little cotton swabs in your mouth. So it's easy collection. And we do it more times in the day. So it is more collection, but more data points to get more answers, especially if you start your sentence with, gosh, in the morning, I'm really inflamed. When I wake up, I'm in so much pain. In the morning, I need 4 cups of coffee. I'm just a wreck. That's when the Dutch Plus comes in really, really handy. Plus you get all the hormones and everything I said.
And I think it helps too, because you get, again, based that, what did I make? Mm-hmm. Right? What was available for use, right? Mm-hmm. Versus what am I metabolizing? And those two things as well don't always kind of match. So you might look at one pattern in the urine if you just did the urine test, but if you looked at the saliva, you might see a totally different pattern, right?
Right. It's because in the urine, it's a grand sweeping collection over 2 hours. And so in that 2-hour time of urine, you get a cortisol awakening response. People will ask me, is it the same thing? I'm like, not always, because depending how fast or slow or blunted your cortisol awakening response, you may have a normal looking urine pattern. But when you look at the saliva pattern, you're like, oh, there it is. There's the pattern. Like that's what I needed to know, is that like micro focused detail.
And then when most people go to maybe their conventional allopathic physician and they're testing cortisol, right? They're typically looking like at a one test. There's 2 options, right? They're looking at cortisol, like one time during the day, or they're doing like a 24-hour urine collection, which really doesn't give us the pattern, right? Which is really what we want to see. Yeah.
A lot of people want to know, why am I tired in the morning? Why can't I sleep at night? Why do I crash in the afternoon? These are the questions we get, right? And that's where that pattern of cortisol can help to say, in fact, I was talking to a client yesterday and her cortisol was high at night. I said, what are you doing at night? And she goes, all the things. My kid goes to bed and I'm on social media, and she owns a business, and she puts her business hat on, those couple hours at night when her child goes to bed. And it's so common. It's, especially now in this current day and age, kids at home, homeschooling.
Yeah.
They're like trying.
It's tough because, to tell them, hey, don't do that, turn all your stuff off. They're like, hello, I don't have that luxury I used to have. So instead of, saying, hey, don't do that, we have to say, okay, we got to come up with a better strategy to help
100%. That's what I said to her. Yeah.
All right. So let's break down the test a little bit. So on the test, we've got something called DHEA and DHEAS. And I think sometimes people don't understand what those are and what the differences of them are. So can you talk about what they are? Yes. How do we get DHEA? And then what's the difference between those two things?
DHEA is the active form of DHEA, meaning with DHEA by itself, no other letters around it, DHEA, it can bind to receptors, turn them on, do the things. Women make DHEA in our adrenal glands, in our ovaries, and in our peripheral tissue. So let's say like fat tissue. Men make it in their adrenal glands mostly, and their testicles. And then when you put the S on it and it becomes DHEAS, it is now inactive. It cannot bind to receptors, cannot turn them on, cannot do the things. And the S is called the sulfated form. S is a sulfate. And so S is basically just like you put the S on and it's like, it's too bad, can't bind. But the body is smart. The body has done that. So it always has a reserve to pull from to make DHEA. And because DHEA primarily is a adrenal hormone, in fact, all of your DHEAS, all 100%, starts out in the adrenal gland and then leaves and floats around the body. It goes with your adrenal health, your hypothalamic pituitary adrenal health. DHEA, no S, has a circadian rhythm. It's higher in the morning, it's lower at night. It kind of follows cortisol. DHEAS doesn't have a circadian rhythm. It kind of just is. The body pulls from it when it needs to, and it puts the S on to neutralize it when it needs to.
So DHEA doesn't have, you said, I think you
DHEA
said
has no S. DHEA no S.
Has a cortisol rhythm?
Has a
no
cortisol rhythm.
Okay.
Yeah.
The DHEAS
with S does not.
Okay.
So people get this confused. They'll run a DHEA. Again, they're going to get their blood work drawn. It's 3 PM. They pop into the lab. They run a DHEA and they're like, oh my gosh, my DHEA is low. I'm like, but you ran it at 3 PM. It's starting to decline through the day. It's possible it was higher in the morning. That's why it can be nice to look at the DHEAS. And I think I read a statistic in a physiology paper that said something like 70+% of our DHEA is inactivated to DHEAS. A smaller percentage than we think is actually reactivated to DHEA, the active form.
So because this is the Thyroid Answers podcast, and a lot of people, we talk about T4 and T3, and T4
Yes.
less active, T3 is the primary active.
Yes.
Is it that kind of association almost that, hey, this is
yes, but
the circulating
more severe.
reserve,
Yeah,
more
more
severe.
severe. Yeah, whereas DHEAS has, to our knowledge, does not have any activity, whereas T4 has some. So
It does. It absolutely can. Yeah.
Yeah.
And that's that's always my concern when we're giving somebody a lot of thyroid hormone, T4 or T3, and we're not aware of what's happening at the tissue level. Because did I send you that study?
I don't think so.
There's a study that I think it's almost all but 1 or 2 types of cancer are increased in people who have been diagnosed with hypothyroidism and are on thyroid medication.
No.
Mm-hmm.
Wow.
So I said, I bet Kelly Halderman a while ago that nobody would ever do a study to show what the long-term effect of taking thyroid hormone is in increasing the potential risk of cancer. And then all of a sudden, 2019, the paper came out. And so, you know, the tie in there is T4. If you flood the body with T4, it can bind to those integrin receptors on the outside of the cell, and it can impact cell replication. So if you have a bunch of sick cells and your body's potentially down-regulating thyroid physiology because I've got sick cells, and now you flood the body with thyroid hormone and you start multiplying sick cells, that may be one of the factors. But that paper didn't get a lot of attention. Yeah, that paper didn't get a lot of attention. But if I remember, I'll pull that and send that to you. But it's an interesting paper. All right, so we got DHEA, right? It's being made, and I've got some circulating reserve of DHEAS. Now, what does it do? You've got these arrows on the report, and so it can go down different pathways. So can you explain like testosterone, androsterone, and etiocalanolone?
Yes. So testosterone is related to DHEA in that we call it in the androgen family. So pretty much all testosterone in men are made in the testicles. In women, we make about 20 to 25% of it in our ovaries, which is really important to know as women say, my testosterone's declining as I get older, as I get into menopause. I'm like, right, you're going to lose, sadly, it's a terrible design flaw. You're going to lose about 20 to 25% in menopause because your ovarian production goes away as you hit menopause. The other 20 to 25% made in the adrenal glands, and then the other 50-ish% is made elsewhere, peripheral tissue, fat tissue, what have you. So those can bind to receptors, like I said, and turn them on, do the thing, or they can get converted into other forms. They're called metabolites. So they're just downstream forms of those androgens. And so one is called etiocalanolone and the other is called androsterone. There are more. These are just the predominant ones that we tend to see a lot in urine. They're the more preferred forms. And who names these things? Etiocalanolone, androsterone. It's beyond, like, I would have picked something way more fun, but there we go. Androsterone is the more androgenic side, whereas etiocalanalone is the less androgenic side. What do I mean by that? Androsterone is more likely, if you continue down that pathway, you're going to end up at DHT, dihydrotestosterone. It's more potent than testosterone. It's more likely to cause cystic acne on the jawline, hair growth in places you don't want, male and female pattern baldness, prostate issues in men, PCOS in women, anger and irritation is a mood change. Whereas etiocalanalone, we call the beta side. It's the less reactive side. It's still an androgen. It's just not nearly as potent. And so by seeing that pathway, we get great answers for men and women who either say, gosh, why do I have this cystic acne? Why is my hair falling out here? What's going on with my PCOS? Why am I so angry and irritated all the time? Looking at that pathway can give us some big insight as to what's going on.
So testosterone typically gets all the love, right?
It does.
So people put a lot of attention on to testosterone and say, well, if my testosterone's low, you just need more testosterone. I've got a patient right now, probably I'll be doing a Dutch on him shortly because his doctor has him, he's got prostate issues and he's got elevated DHT in blood. We'll talk about blood versus the urine in a second. And they has him on testosterone therapy. So if you're going to put him on testosterone and you know he's got a prostate problem, maybe we should make sure that that pathway is cleared out, or maybe we shouldn't be driving that until we've addressed the other parts.
Yeah,
issues
exactly.
as well.
Reduce the dose, or consider the other things first. And I'll have practitioners call me and go, do you think I should work on the pathways first and then give the hormone? And it depends on the person and their symptoms and what's going on and the risk factors. But yes, it's a possibility. If you'd rather, in that case, they already know they have prostate issues, maybe work on the pathway, that pathway and the estrogen pathway, which is linked with prostate cancer. Work with those first and then consider the hormone.
Make sure the drain's clear before you dump a bunch of crap down it, right?
Exactly. And what's great is that some of this is lifestyle dietarily modifiable. Shocker. I know.
Get out of here.
That pathway, that testosterone, DHT, androgen pathway is upregulated by inflammation. It's upregulated by high insulin. It's upregulated by stress, cortisol, glucocorticoids. So when men and women come to me and say, I'm a stressed out mess, I feel inflamed and puffy, things hurt, and I'm on the pandemic diet, so I'm doing a lot of snacking, a lot of alcohol, and here are my symptoms: acne, my hair loss is getting worse, anger issue, whatever. I'm like, okay, let's dial this in, because these are big red flags to that pathway to turn it on.
So let me jump in there because I want to make sure people understand what we're talking about. When you're talking about that pathway is going to get turned on or upregulated, are you?
There's an enzyme. There's an enzyme called 5-alpha or 5-beta reductase.
Okay.
So that little enzyme is it's when it's made, it can be made more. So the production of it, the little factory that makes it, can be turned on higher, faster, stronger, again, with inflammation, stress, insulin, high insulin. Some people will say, like, well, isn't insulin normal? It is. That's normal physiologic insulin. It's when you have a lot of insulin all the time. That's when we get into trouble.
So in an early phase of like stress and inflammation and all this stuff going on, are we going to get an upregulation of the whole pathway, the DHEA, everything coming?
You could. You could. It depends on the person, 100%. But in early stress, and symptoms help. In early stress, when women say, I'm losing hair at my temples, I'm losing hair at the crown of my head, my face is breaking out. I don't understand why my face is breaking out. I'm irritated and angry all the time. It's like, oh, sounds kind of like that androgen pathway is being upregulated. So that can be really helpful and then get into testing.
And so when we take a look at like acute phase, we might really see that ramp up. In the chronic phase of insulin resistance and chronic inflammation and chronic stress, could we see the opposite? Like, hey, now I'm not making this stuff as well anymore.
I honestly I don't see it in women. I see in a chronic phase. So let's like in a polycystic ovary syndrome, PCOS, that has high insulin. So dysfunctional insulin regulation. Insulin really presses on the production of testosterone and androgens out of the ovaries. It's a big signal to the factory in the ovaries to make androgens. And it seems to be perpetual unless you get it under control or hit menopause. And so I don't, in women at least, I don't see it wear out, burn out, or have a negative feedback loop.
Okay. And so do we know what the mechanism is, or like, do we have an understanding of, man, doesn't that seem counterintuitive? Like, have I got this high inflammatory process? Why am I jacking these androgens so high? Do we have any idea?
I'm assuming it's part of like a survival thing, right? I'm assuming it's to get the DHT, to put the DHT up there, like something must be wrong. It's fight or flight. And so it's like, all right, let's get you angry. Let's get you hyped. Let's get like the acne and the hair loss and stuff. Like that's a byproduct. Like that just, that clearly has nothing to do with survival, but putting you into that 8 times more potent testosterone state, like, you know, turning you into the Incredible Hulk in theory. I'm assuming that's a survival thing. You're inflamed, you're stressed. The body's like,
Yeah. So that's exactly what I was trying to get from you. Is like, hey,
yes, I passed the test.
Is that, hey, this could be a defense response, right?
Yeah.
Why am I not doing estrogen? Why am I doing more of this?
Mm-hmm.
Well, hey, if I'm in danger mode, if I'm in survival mode, do I want to make myself fertile and do this while I'm doing that? Maybe not. Maybe I need to focus on survival. That's my primary issue. It's kind of what I talk about a lot when somebody says, well, why do I have, thyroid physiology problems? What's going on? I always talk about, look, your cells are like you. If you're cooking in your kitchen, you got 4 burners on, you have your kids are at your island, they're having a great time, and somebody breaks in and starts attacking one of your children. What are you going to do? Are you taking the time to turn the burners off and wrap it, put everything else in nice glass Tupperware?
Hold on, let me get my glass, my glass containers.
And then, people are like, no. I'm like, okay, are you gonna clean the house? No. Are you gonna be doing wash? No. Are you gonna be having sex with your spouse? No. So what you're gonna do is spend all that time and attention on survival.
Yep.
And so when we have somebody who's got hormone issues, pregnancy issues, fertility issues, I'll let you talk to this, but should we, instead of saying, hey, let's just put more in here, it's got to work, take a step back and say, wait a minute, the body's probably not in that mode right now. So maybe we need to use tests like the Dutch to figure that out and then figure out why we're in that mode. Right.
And the same goes with even supplements or medications that block, so to speak. So blocking the 5-alpha, blocking the estrogen creation out of testosterone. I will get asked that a lot. Like what supplement, what medication can I take just to stop this cascade? Now, the medications and the supplements are helpful Band-Aids while you're doing the work. But if you're not going to address the inflammation and you're not going to address the insulin and you're not going to address your fight or flight response, then they're only so helpful. They're only going to get you so far. They may work for a minute, but then they're not, your lifestyle and circumstances are going to overwhelm even the medications that are strong, and it's going to continue. So I want to make that point because I get asked that a lot. Like, oh my gosh, I have acne. I have on the Dutch test, that whole pathway is upregulated, on fire. What do I take? What supplement do I take? I'm like, let's find out what the trigger was. Hold on. Let's back up and work on that. Yes, supplements and the medications. Well, the medications are kind of gnarly, but the supplements, great Band-Aids, but they are not a standalone platform. Like you have to do it in conjunction with working on your stress, working on your fight or flight, working on your inflammation, working on your insulin. And
that's part of the difference in the philosophy, I think, in functional medicine is get to root issue. And so when we're talking about that, hey, the medication, your allopathic physician isn't wrong. They're doing exactly what they were taught, right? But their philosophy about it is, this is what we do. This is how we stop it. And in functional medicine approach, we're really trying to say, yeah, I get it. If you need it as a Band-Aid, okay, but we got to get to this root issue, or you're going to need something long-term.
Right.
And, you know, maybe if you don't care and you just want something quick and easy, the medicine might be the fastest, quickest way to get what you want versus doing the supplementation. So we've got these hormones. We've talked about the 5-beta pathway for the androgens, the 5-alpha pathways. That's the more dominant. Is there a time for somebody, let's talk female or male, I guess you could break it down, that there's a real benefit to having higher levels of 5-alpha metabolites or higher levels of 5-beta metabolites?
Well, a lot of it is genetic as well. So some people don't really have a choice. We talked about diet and lifestyle factors that can push the alpha pathway, but when you create that enzyme that does it, either the alpha or the beta, again, a lot of it's genetic. I have a very alpha personality, but I am very beta in my androgen production. I don't make hardly any DHT. My 5-beta is very upregulated through my whole body. It's the same enzyme family does progesterone, the same enzyme family does cortisol. And so I can just see it genetically. I'm a beta converter. And so sometimes it just is what it is. It's the cards that you were dealt. But are there any times when maybe it's helpful or beneficial? Again, like I would say with the well, I'm trying to think of like when I would want somebody to be in this perpetual.
So let's say I'm a person who
so.
doesn't have very high levels of testosterone. In that situation, would it be more beneficial for me to favor a 5-alpha pathway?
Yes, if you have lower levels, then it is probably more beneficial to favor. Now, if you add in testosterone, you may not be happy after a while. You may get all the side effects and symptoms, but if you already have low levels of androgens, but favor the 5-alpha side, that may counter effect. Your doctor may say to you, "Oh, your testosterone's low," and you're like, "Well, I don't feel it. I don't have any. I have great energy. My libido is great. You know, I can put muscle on, not a problem. My mood is good." But that DHT is potentially making up for it for you.
And by looking at the test too, and we know if you're a 5-alpha, if you favor 5-alpha or 5-beta, it could be epigenetic, which means your diet and lifestyle are impacting whether you're favoring. Yeah. But it could also be very helpful to know that, look, I favor 5-beta across the board. If I'm going to go on androgen therapy as a guy or a gal, it's important to know, because I may need a different dose or a stronger dose. Hey, this is our normal dose. Yeah, but this is a person who favors the 5-beta pathway. They may need a stronger dose to get the same effect that somebody who favors a 5-alpha pathway, correct?
Right. We still have to be careful of the 5-alpha path. You know, like there's still the metabolites of that we, especially in males, have to be careful with prostate health. But there's a difference between low or in the range, physiologic range, or way above the range. You know, that's where our art and talent and science comes into it, of like, oh, actually this now puts you in the normal range from the low range. So like you're right where you should be. And that's why you feel better.
So when we take a look at what we see on urine versus blood for the androgens, how do you tell and somebody looks at it and says, well, my testosterone levels are high, what should they expect on their urine tests if, let's say, blood levels are high? Should the urine metabolites match that?
Usually they should match that. Now, what comes through the urine is we call bioavailable testosterone. So and that's different somewhat than what's in the blood test. So in the blood test, you're going to check a total testosterone. You're going to check a free testosterone. You're going to check the binding globulin that can bind it up. It's called sex hormone binding globulin. So you get these different pieces and parts of testosterone. Once you come through the liver and then the bladder, the kidneys and bladder, and come out in the urine, we call it bioavailable testosterone, which is a combination of free testosterone and testosterone that was bound to something called albumin. So it's not apples to apples, urine and blood work, but it is pretty close, especially as it relates to a free hormone state. Some labs do look at bioavailable testosterone. I am seeing that more. I'm seeing more practitioners check bioavailable. Bioavailable, again, just means free plus testosterone bound to albumin. Albumin is just a carrier protein, and testosterone binds to it very weakly, meaning its other binding protein is sex hormone binding globulin. Picture that like a bus. You're in the bus, you're seat belted in, super strong, like the doors are locked, you cannot get out. That's the bus you're on. Whereas albumin, you're kind of like tied to the top with the bungee cord. Like you could fly off at any time. That's the relationship that testosterone has with albumin. So it's really easy to become free, which is why they call it bioavailable. They can just pluck off the bungee cord and let it go. So the Dutch test testosterone is not the same as the blood test testosterone, but they do often overlap pretty close depending what you're checking.
Okay. Unless maybe something like the upregulation of an enzyme or two might create some issues there. So,
so if you have an upregulation of the clearance of testosterone through what's called sulfation or glucuronidation, big fancy words for clearance types of detox, then you are going to clear you may have okay levels in the blood, but higher levels in your urine, or you may have low levels in the blood and higher levels in your urine. But if you know you have an upregulated phase 2, an upregulated sulfation, an upregulated glucuronidation, maybe you've done genomic testing, then you're like, okay, I have low levels because I'm clearing this out.
So now we've got the estrogens, right?
The estrogens.
And we've got primary estrogens, and we got 3 of them. So let's talk about those. How do we get those? What percentage of that is coming from DHEA, and how does that happen?
So your estrogens are primarily made in your ovaries when you're cycling. So in your ovaries, your androgens that we've just spent a lot of time talking about are in one particular cell called the theca cell. And they diffuse over, they float over and go into the cell next door in your ovaries called the granulosa cells, and they convert into your 2 main estrogens. One is called estrone and the other is called estradiol. And it's primarily estradiol you convert into. And so that's primarily how women make estrogen, is that you take the androgens, that's step 1, and you convert them into your estrogens. Men are a little different. Men use the same conversion. They just do it in other tissues like their fat tissue and their skeletal tissue. So men totally make estrogen. Men even make progesterone. They just do it differently, really differently than the way that women do it.
So if a woman has, that's what we were talking about before, if your estrogen levels are down, then you're not getting that conversion at those at that tissue to do it.
And the enzyme there is different. It's called aromatase. Aromatase, as opposed to when we were talking earlier about 5-alpha reductase, they sound similar. Aromatase with an A is what does the conversion to estrogens. Yeah, and so if it's down regulated, if it's low, or if you have low androgens to begin with, you don't have a lot of testosterone as a female, then you could struggle to make your main estrogens.
So if you're thinking about what's the enzyme, like you think about women smell good, like they have a beautiful aroma, and that's how you get there, right? That's one of the ways to remember it. So now we've got the primary estrogens. So we could take blood estrogen levels.
Totally.
How do our blood estrogen levels compare to what we're seeing in the urine, and how much should we see in the urine as primary metabolites, as phase 1 metabolites and phase 2? Because I've had that question asked to me, but I have it in the blood and it's also in the urine, but then there's metabolites. Like, so how much, what should be the difference here?
Right. So the report, to make it simple, when you look at a report for the first time, we have a lot of dials. And so the dials, we've kind of simplified a very complex detoxification pathway. So we have a paper that was published in 2019 that compared urinary estradiol and progesterone and serum estradiol and progesterone and showed they correlated really, really well, which is great. Now, do they always correlate? No. And it does depend on what blood work you're getting. So when you get your blood drawn at a lab, you can get it done through immunoassay, which is less sensitive and specific, or you can get it done through mass spec, which is way more sensitive and sensitive and specific, and a little more expensive. And so depending how you get your blood drawn at your lab will also dictate, because I'm seeing this more of because the immunoassay is not the highest end technology, that when blood results come back kind of weird or not what I expected, I'm like, can you rerun that as a mass spec? And then we find the results maybe much more match the urine or much more match what I was expecting. So first things first, how you test your hormones in your traditional lab, the hospital, the lab center you go to matters. Immunoassay, not as specific, not as sensitive. Mass spec, much more so. So then after that, then you go through, you get rid of your hormones, right? You're done with them. You need to clean them out. So you go through 3 phases of estrogen detox. Phases 1 and 2 primarily happen in the liver. They can happen other places, but primarily in the liver. And so on the Dutch test, we look at something called the hydroxylation, which is phase 1. And we look at methylation, which is phase 2. That's what we report. But you also have a sulfation and a glucuronidation and acetylation. You have all these other markers that go with detox, but we report to you hydroxylation and methylation to see which way you are going as you come through the liver and into the kidneys.
So is there when we look at the primary estrogens, if somebody's saying, well, if it's supposed to all be metabolizing, why am I seeing any E1, E2, E3?
Because it's getting sulfated and glucuronidated and coming through the kidneys into the urine. We just don't report it as estrone sulfate or estrone glucuronide. So to make it easy, we show you estrone and estradiol.
Okay. So those could be the sulfated forms and the glucuronidated forms. So they're not primarily the same thing.
They're not, it's not apples to apples. But in order to get sulfated or glucuronidated, you have to be obviously have been estradiol or estrone at one point floating around. And then we take the glucuronide and the sulfate off in the lab and leave you with the free estrogen, so to speak. And that's what we report. Okay. So we report the free estrogen just like they do in the blood work, but how it got there is it had to go through sulfation and glucuronidation.
And why I think that's really important to point out is because if you had high levels of estrogen in your blood, and I look at this and I see low levels of primary estrogens in the urine, we might assume that the test is wrong because I have levels there. But really what it's telling us is about the detoxification path, like how good a job we are doing sulfation and glucuronidation, correct?
It does. That's part of it. Yes, 100%. The other part of it is you had said in the very beginning about trying to get blood work done on the same day as the urine test. Because having seen thousands and thousands of tests at this point, it's a one-day test no matter what. So I got an email actually right before this from a practitioner who said, I have all the symptoms of estrogen dominance, but my Dutch test showed low estrogen. I'm really surprised. Why is that? Because after ovulation, after you release the egg, your estrogen dips down and then starts to come back up again. And so there is a test that we do and other companies do as well, where you look at a woman's estrogen and progesterone through her whole cycle. It's often called like a cycle mapping as an example. And having seen thousands of them, I can tell you that estrogen can bounce around. And so if you happen to test a one-day test, like a blood test or a serum or a saliva test or a urine test, on the day your estrogen dips down, but the next day or the day after you go back up again, that's where it gets challenging, because I've absolutely had women go, I got my blood test done and it says that I make plenty of progesterone, as an example, plenty of progesterone, but I have terrible PMS. And then I do the cycle mapping and they do have plenty of progesterone. And then it literally falls off a cliff the next day or the day after. And so sometimes it's nice to hyper focus, but sometimes we have to step back too and look at the whole big picture. Women cycle. And if we're not looking sometimes at the whole cycle and we're just focusing on one day and one hormone, we have blinders on and we miss the whole forest. We're just looking at one, we're just completely obsessed with the tree. And yet we've missed the whole forest. So absolutely the blood and the urine may be different because of detoxification processes. And it also may be different because you actually got the blood test on the day that your estrogen rebounds, and the urine test you didn't. You did it a few days earlier or what have you.
So that's why
I see that. And so it could be or both. It could be both. You could still have a rebound thing, and you could still have a detox thing. And that's why working with a practitioner who understands hormones and understands, above all else, women's cycle, that's helpful.
So let's talk about E1 versus E2 versus E3. So most people are definitely familiar with estradiol, but they're not quite sure what E1 and E3 are. So can you explain those?
Yes. So E2 estradiol is the most potent estrogen in the body, meaning when you have receptors for estrogen, that your estradiol binds at those receptors at 100%. They are a perfect key in lock match. Estrone binds, I believe, at about like a 10%, under 20% at least. Meaning if estrone and estradiol got to the receptor at the same time, estradiol would win every time. Estrone is more common, more produced in menopause because it's primarily made in the peripheral tissue, the fat tissue. So when that enzyme aromatase happens, estrone is primarily what it makes first. But estrone can convert itself into estradiol, and then it can go back and forth. There's a whole other enzyme that does that too. So estrone is they call it it's a weaker estrogen, and it has the ability though to become a potent estradiol estrogen.
So is it fair to say that estrone could act kind of like as a circulating reserve to some degree?
So estrone actually can be sulfated, estrone sulfate, and it doesn't have to get cleared out. Like DHEAS, you have estrone S, and so you have way more, heaps more, 10 times more estrone S than you have estrone, and they call that the estrogen reserve because you can pop the S off, make estrone, and then use the enzyme to convert it into estradiol. So it's a very quick 1, 2, 3. And so estrone, yes, to a degree, it's a nice little estradiol reserve, but estrone S, just like DHEAS, is the bigger, way bigger reserve.
So if somebody said to you, Dr. Jones, which one of these primary estrogens should I be most worried about causing my estrogen dominant symptoms, what would you say?
In the moment, it's estradiol. So in that exact moment, it's E2. But I have to keep an eye on estrone because I know it's potentially going to turn into E2. so if your estrone is actually higher than your estradiol, I'm like, it's weaker, but the potential is there. So let's not upregulate that potential.
Right. And I think we see sometimes, and I think you and I have talked about a test in a gentleman with extremely high estrone levels, right? And he's taking aromatase inhibitors, but is having all the chronic classic signs of estrogen dominance from a dude. And if you just looked at his estradiol on the blood, it looked okay.
Yeah.
But his estrone levels were like, when we looked at the estrone levels in the blood and the urine, they were really, really high. Yeah. Because he was, and I think your comment was the drug can only do so much, right?
Right. Yeah. And he may also have a sulfation issue as well. So he can't put the S on. So even though he can't neutralize his estrogen, so to speak.
So it's going.
Yeah. So it's just staying as estrone because it can't get neutralized, and he's on testosterone, so he's constantly getting the precursor to make it, the building blocks to make it.
So what about the metabolites? So we have the 16, the 4, the 2OH. What are they telling us as when we're taking a look at that?
Phase 1 detoxification, that entire section 2, 4, and 16. So those are pathways that estrogen can go down. Like I said earlier, it's called hydroxylation. So the pathways will never be zero. You are going through estrogen detoxification, just like other detoxification, 24/7, 365. It doesn't slow down for your birthday, Sunday, Christmas, none of that. It doesn't take a break. And because of that, it's really helpful to know which pathway you prefer. The 2 pathway is considered the less carcinogenic. It's not zero carcinogenic. It is just less carcinogenic. So less risky for cancer formation. The 4 pathway is the more carcinogenic, more risky for cancer formation because if it continues on that path unchecked, then it can create things that cause DNA damage. And we don't like that. The 16 pathway we call the proliferative pathway. It makes things grow. Not great for breast tissue. If you already have breast cancer, it can cause growth. Maybe not great as you get close to your period and your breasts get full and tender. Maybe not great for fibroids or clots when you get your period and have clots. But they show that it is helpful for bones because The 16 pathway is estrogenic. It can bind very, very weakly, very mildly to the estrogen receptor and turn it on, which is why it can be helpful for bone health. So you have these 3 pathways you choose from, and the ideal is to be way more 2 compared to the 4 or the 16.
And then we've got, and that's phase 1. So that's going to make that hormone more fat soluble.
Well, no, I'm sorry. Phase 2 makes it water soluble. It is fat soluble. Correct.
Right.
Right. Sorry.
So if we have a problem with that building up, where's that go?
Right in the cell. Right inside the cell. Fat soluble hormones just slide right in. They don't need an invitation. They don't need a transporter. They don't need a gatekeeper. They just show a badge and keep walking right inside that cell.
So the liver is trying to take this substance, and it's got to go through a couple steps. One is this first phase 1, which makes it more fat soluble. Yep. And then it wants to take it and make it more water soluble.
Yes.
So that we can pee or poop it out. So you can talk about that a little bit for us.
Yep. So that's called, in our test, it's methylation. So methylation is just what you said. It neutralizes it. It takes a methyl group from something called SAM. A lot of people may be familiar with the supplement SAMe. It's the M in SAM. It takes that, uses magnesium as a cofactor. So magnesium is really helpful here, and puts it on the estrogen metabolite, neutralizes it. Now it's water soluble in the cell. Can't cause more damage in theory.
So when we take a look at these the estrogens, and you look at the dial from a simple person's perspective, what do they want to look at from dial, from primary to phase 1 for phase 2? Can you give them a general guideline about where those arrows are?
Yes.
That they can get? They don't have to know phase 1, phase 2, phase 3. You don't need to know the mechanisms, but what's the easy thing they can look at on the dial to say, maybe I got a problem here?
When you look at estradiol, E2, and when you look at the 2-OH dial, and when you look at the 2-methoxy dial, they should all be facing in roughly the same direction. Because it's like a clock. And so even if your estrogen is high, even if you have a lot of estradiol, your phase 1, 2, the 2-hydroxy should also be high. And your 2-methoxy should also be high. They should match each other at relatively the same rate. So the numbers won't be the same, but look at the dial, the little arrow, and see if they're facing the same direction. If they're not facing the same direction, if your estrogen E2 is high, but the rest of everything's low, then you know you have a sluggish or slow detoxification. And we need to dial those dials up quite literally. If the naughty 4-OH dial is high or matching, pointing in the same direction as your high estrogen, that's not good either, because that pathway is the one I said is more carcinogenic. If your 16 is facing the same direction, again, it's more carcinogenic. So it's not about so much like my ideal number. I'm looking to see, can your detoxification pathways keep up with the clearance of the estrogen you have in your system? And if it can keep up, fantastic. Fantastic. It's like, can you keep up with the dog hair that sheds in your house? If your dog may shed a ton, but if you can keep up with it, it's all I care about. And so I cannot keep up with my dog hair. So it's a lost cause.
if you see that E2 is lower, your 2-OH is higher, and your 2-methoxy is lower than the 2-OH, then what you should be thinking about is, hey, I'm stuck here somewhere.
Yes.
That phase 1 is not, I'm going from primary to phase 1, but I'm not getting the stuff out. What's the downside to having that elevated phase 1 metabolites in the system?
It's not zero carcinogenic. It can still cause, they're called stable adducts in the DNA. They can still potentially cause some DNA issues. Still reactive oxygen species creation. So little inflammation, little fires. So we have to still be careful of the 2-hydroxy. That other 2, the 2-methoxy that we report, is actually very helpful. It's very anti-cancer based on some research. But the one prior, the 2-hydroxy, again, it's safer. It's just not 100% safe. And so I don't like when I hear maybe educators, they call it the safe the pathway, you know, the healthy pathway, the non-cancer pathway. I'm like, no, it's still, I mean, the risk is like small, but it's still there. It's not zero. And so we want to be careful with it.
So I want to be respectful of your time. I know you have things to do, and we'll get you back to go through the rest of this, but I'm glad we got a chance to break this down quite a bit. I mean, we could spend, given time, we could geek out for another 4 hours here.
Oh my gosh.
So a couple key things that I want to just kind of point out is that there is so much that can be learned from this test.
Yes.
And I think just like many other tests, there's levels of learning. Mm-hmm. And so there are people who are kind of new into functional medicine and new to getting a Dutch test. And they're kind of going to know some of what's going on. Other physicians are going to be really good and be able to say, okay, we're not going to just, they're not just looking at it in kind of the protocol, like how do I use DIM, I use this, but really so I think there's, as the longer you do the test and the more practice and skill you get, instead of trying to treat a protocol, which I think sometimes happens, what we start to see is that you start to understand the why. Like if this is high, I need to do DIM. Okay, great. And that's maybe for another podcast discussion. But really what I think we want to say is, okay, yeah, I can use DIM to shift that down the better pathway, but the more skilled the provider gets, they're going to be able to say, okay, but let me explain to you why that's occurring.
Right.
Or
absolutely. Hey, or why not? Because as you know, I beat the drum that DIM is not for everyone. Right. All the practitioners give DIM out like Oprah gives out cars. And I'm like, DIM is very specific, and DIM probably should not be given to the menopausal woman not on HRT. And the DIM is not a panacea. It's not Nutella. It's not chocolate. It can't like cure all things. So you gotta be careful.
Yeah. So it's important for somebody to understand, like, hey, if there's different levels, when you find somebody, your practitioner who's doing this test, you might find that different physicians, different practitioners have different levels of understanding here. So you can see one practitioner and they tell you one thing, maybe to some degree, and you might see somebody else and they may get a whole different level of information out of the test, which is why Dutchess does a great job in helping physicians. And if you are a functional medicine practitioner and you're getting started using the test, I highly recommend using some of the guidance so that somebody at Dutch who's experienced in doing this can help guide you to get the most bang for your patient's buck out of this test. Because there's so much. And when you can take a look at this and then take a look at their regular blood chemistry and maybe their hormones, man, you can learn so much. And I think you can do a lot more with less when you really understand the depth and breadth of it.
Yeah, I would absolutely agree. And we fully realize that not all practitioners have a background in hormones. So practitioners may have been in medicine years. Yeah, I mean, I have converted internists, I have converted ER doctors, I have converted, whatever, rheumatologists who got into functional medicine. And they're like, Carrie, can you just explain the menstrual cycle to me? Like, it's not my thing. Like, can you just help me with the basics as I get into understanding hormones more? This is a high-level comprehensive test. You get a lot of information, but for our Dutch account practitioners, like, we're here to help you because we understand it's what we do all day, but it may not be what you do all day.
Right. And I think that's key because there's just so much to know and you can't know everything. And I was having that discussion with you. The moment you think you know everything, you're probably wrong. Right. So I'm going to let you go. We're going to bring you back to do cortisol. Then we'll probably need a day just to do organic acid markers.
Oh my gosh. I know my organic acids, but the organic acids in general, you probably know way better than I do.
I don't know. I think you know those things pretty well. So, but I think that's a discussion because we see things like the HVA and VMA that there's a ton of confusion about those. Hey, they're low, I'm good. So that's a whole nother conversation discussion we can have. So
for sure.
Thanks so much for coming on the podcast. I'll let you get back to work. If somebody wants to know more about Carrie Jones and where they can find you, just let them know.
On Instagram. I hang out on Instagram with Eric I'm at dr.carriejones. Everything on there is lots of education.
She legit has the best Instagram stuff, Instagram posts, and put it out there. And I think what I really like about it is that you put it into language that makes it really easy for people to understand, layperson or physician to understand.
Thank
So
you.
I appreciate everything you do. I look at you like my resource when I need extra information
Same,
or
Eric,
just
same.
a clear, objective, unbiased brain to look at something and say, what are you thinking? Or this is this is what I see, or a confirmatory comment like, yep, that's right.
Yep.
So I appreciate everything you do. Appreciate you educating the masses. Have a fantastic rest of your weekend though. Okay.
You too. Thank you so much.
All right. Thanks. Take care, everybody.